but when it comes to brain tumors, brain tumor, strictly speaking, is anything within the skull. There are some tumors of the skull that go to the brain, some tumors of the brain that go to the skull. We're not going to worry too much about that. We're going to try to keep things simple. So when it comes to classification of brain tumors, anybody know any type of general classifications at all? For any tumors? Benign, malignant is one, right?
I thought it was a trick question. That seemed like the easiest.
Yeah, and then primary or secondary. And so what are primary tumors? If anybody works in the unit, gliomas, meningiomas, anything that starts in the brain. So any cell of the brain can potentially cause a tumor or cause growth, just like anywhere else in the body. It's not a, and then, so primary and secondary. Secondary are going to be your metastatic disease. And that's going to be most commonly lung, colon, breast, and then renal, and then you can get into the weird and wonderful. Certain genitourinary cancers can metastasize rarely, and other ones. So primary tumors, they can be just about anything that starts in the head, and there's a long list, but meningioma, and then you can have your gliomas. And meningiomas are tumors that start on the surface of the brain and then kind of travel in and push on the brain, and gliomas arise from cells within the brain. So your glial cells, your oligodendrocytes, your astrocytes, any supporting tissue or neural tissue of the brain can form a tumor. So how about, a lot of times you'll be reading the report, radiology report, and you'll hear extraaxial and intraaxial. So all the difference in that is an extraaxial tumor would be something like a meningioma. So something that starts outside the substance of the brain and then grows in, and the intraaxial are those like the gliomas that grow, from within the brain substance. They take up brain tissue. So extraaxial tumors tend to push things out of the way. They're typically benign, not always. Some meningiomas can be malignant. Metastases can be extraaxial. You can have dural-based metastasis that push things out of the way. Those are malignant tumors. And then your intraaxial typically tend to take up space within the substance of the brain, and then once the mass effect gets large enough, they can push brain out of the way as well. So that's a general classification of tumors: benign, malignant, intraaxial, extraaxial, primary, secondary, and there's probably a whole host of other classifications, but that's keeping kind of things simple. So when it comes to diagnosis, as with everything, starts with your H&P. So patients may give a history of headaches. They may give a history of right arm weakness. They may give a family history. An elderly individual just hadn't been acting right over the past 2 months. There's been a steady decline. So other symptoms, those are the main ones. And then on physical exam, you may find somebody complaining, or you may find on exam that they have a right-sided weakness. They have a abnormal pupil. They're not arousable. They're difficult to understand. They have speech abnormalities. Sometimes that can be a slow process that builds up. Sometimes it can be an acute process. So it's unusual for a tumor to cause a sudden onset hemiparesis, but if you have that, it's usually in association with a seizure, in association with a hemorrhage, in association with a stroke or a cutoff of the blood supply. So once you have your symptoms that the patient talks about, your physical exam that you find, if you have a lateralizing finding that's been a slow progress, that's a tumor until proven otherwise. So then you move on to your imaging. And these are predominantly everybody that walks through the ER with a headache or anything abnormal gets a CAT scan, right? And the reason is because if they have a stroke that's acute, then they need intervention for that. If they have a hemorrhage that's acute, they don't need any intervention because they'll bleed. If it's a mass, then they don't need any intervention for the stroke as well. So CT gives you a gross picture of what's going on, and then you progress to an MRI. And then we don't use them too often within the hospital, but PET scans are used sometime. Other diagnostic procedures, angio, to make sure it's not a vascular problem. It looks like a tumor, but you come to find out it's an aneurysm. That'd be a bad day if you went in and tried to take that out without knowing that it's an aneurysm up front. Other diagnostic things, you can do an LP. Sometimes if somebody has a lot of cranial nerve deficits and they have this enhancing dura, they can have carcinomatous meningitis. So an LP, that's not really treated surgically, but an LP would tell you if they have a lymphoma, a metastatic disease that's diffusely spreading. That's a bad prognosis. And then going on from diagnosis is definitive diagnosis. So how do you know what you're dealing with? And that's basically where we come in, either through some form of intervention. And that's generally surgery. And then surgery can either be a biopsy, and that can either be a stereotactic or open. So you get, patients, they all come to the unit, they all get, and you can look at the op note, and if it was a frameless stereotactic biopsy, that's going to be a very small burr hole, and then a needle was passed down into the abnormality. Generally very safe. About 10% of the time, though, you'll have a hemorrhage associated with that, so it's important to know. And then an open biopsy is a formal craniotomy. We know we're not going to get it all out, but we get several pieces of the tissue just for diagnosis. And then the other option is resection. And resection can be, subtotal or gross total, what we call it. And some tumors, depending on the location, you know going in that you're not going to get it all out. It's going to be a subtotal resection, but you're debulking the tumor for mass effect. A gross total resection is something that we start out in the front and tend to take everything out that's abnormal. When it comes to meningiomas, the more benign extraaxial tumors, a gross total resection is usually achievable. Not always. And we can usually get around the tumor. There's usually a separate plane between the tumor and brain. The intraaxial tumors, the gliomas, the GBMs, the astrocytomas, those are infiltrative tumors. You'll see us talk about a gross total resection, but that we know that we sort of lied a little bit because there's going to be cells at distant sites from that tumor. The brain is not like in another part of the body, or you can't amputate. You can amputate an arm if there's cancer of the arm or a leg, but you can't take a centimeter of margin around a tumor. So we know there's tissues left behind. So once we know the diagnosis, if it's a benign mass, then we're pretty much done, and we watch for recurrence. If it's and some of the intraaxial tumors can be benign as well. In children, juvenile pilocytic astrocytomas, low-grade gliomas, oligodendrogliomas, any cell name can produce a tumor. Some of those are benign, or what we call WHO grade 2 tumors. Those will often be watched without any intervention. But after surgery, there's usually some sort of plus or minus chemo or radiation. Some places are doing focal chemo within the brain and implantation of radiation within the tumor cavity. We're not really doing that much here, but then the radiation here can be either focal or more like whole brain radiotherapy. Focal is your stereotactic radiosurgery. The whole brain radiotherapy is just like it sounds. It's a blast of radiation. It hurts good and bad tissues. So now that we got our classification, we have how you diagnose, intervention, usually surgery plus or minus chemo or radiation. So when it comes to you guys and girls, the important thing is kind of your post-op care. And everybody's got their different idiosyncrasies of what they like done. The big important thing is know the physical exam from a preoperative status. So it helps you understand that when you get the patient and you're checking them in, and all of a sudden, you find that they can't move their right arm. Was that present preoperative, or is that present postoperatively? Is it something they would expect? Sometimes we resect a tumor and we know that we're going to cause some sort of a deficit, or it wouldn't surprise us if they get a deficit. But if the exam is the same as preoperative status, then you don't rush and get a CT. You don't rush and get too worried about it. However, if somebody, 2 hours post-op, they're still obtunded, they have a blown left pupil, they're not moving one side, and you read back and it says neurologically intact preoperatively, then that's a problem. So know your physical exam. I'm a big fan of BP control, not within really strict criteria, but it's really avoiding hypertension. And the reason is if you ever, anybody is welcome to come to surgery to watch this, but if you're ever in surgery and you're done with the tumor resection and we're drying up, and then for some reason there's a spike in the blood pressure up to the 180s, 200s, everything starts to just kind of ooze and bleed. And and then you have to kind of start all over and get things dry again. When it comes to, important thing to remember, when it comes to things benign, malignant, extraaxial, intraaxial, it's all within a confined space, so bad things can happen. And if anybody's been around long enough, they've seen really bad things happen from a very benign tumor that seems like an absolute chip shot. You're patting yourself on the back, then all of a sudden you get a call 2 hours later, patient's not waking up, they're hemiplegic on one side, they got a blown pupil, and you get a scan and there's a big postoperative hemorrhage. You're going back to the operating room. So benign and malignant have kind of different connotations when it comes to the immediate postoperative care of brain tumors. So BP control, steroids are often needed. Oftentimes they'll be on beforehand, sometimes not, but we irritate the brain. There's often some swelling and we'll put patients on steroids. Back up to blood pressure. I usually just like to keep it less than 140, just avoiding hypertension. It's an easy way to do it. I don't know what the other guys do, but that's generally what I'll write. Steroids, most everybody put on 4Q6 decadron and then wean down pretty quickly unless there's a significant amount of swelling. Seizure prophylaxis, and everybody's probably different as well. Oftentimes I will not put patients on postoperative seizure prophylaxis because you put them on it and then it's kind of, what's the next question is when do you stop it? So I usually wait and see, unless I know if the interaxial tumors, these have a much, like the gliomas where you're actually going into the brain tissue, those have a higher rate of seizures, so it's probably reasonable to put those on postoperative seizure prophylaxis. Meningiomas, if there's not much brain irritation, I won't even deal with it and leave it off. And then if there's any question about patient status, the best thing to do is call and get a scan, because oftentimes we're very surprised at what we find. Somebody looks good, but you're just not happy with how they look. They should be looking better, and come to find out, you get a scan, there's a post-op clot or something. Seizures can present very subtly as well. They can have a subtle seizure that you may not have recognized and be completely plegic on one side. Get a scan, everything's normal. And usually that will get better, and it's called a Todd's paralysis, if anybody's seen that. And then, the rest of the stuff is kind of surgery in general. Early mobilization, I'm a big fan of that, even when it comes to aneurysms or anything else. I think getting the patient up, not keeping them in bed is a good important thing. And then moving on from the ICU units up to the floor, and most patients go home and do quite well. So, any questions about that? Yeah, quiet bunch. All right. Thanks. Is that it? All right. You're welcome.